Okay, we're now live. Hopefully you didn't see that. Okay, we have 11 cases. So if you saw that one, it's only 10. Oh, abdominal pain, large mass, right lower quadrant. That's small bowel. Interestingly, the mass is ulcerating, but it's not obstructing the bowel. So you could think about tumors, right? You could think about adenocarcinoma. Usually it's not so bulky, just is not diffuse like that. This is more like lymphoma. You also could think about metastasis. There are nodes in the mesenteric. Metastatic melanoma, metastatic breast cancer would be possibilities. You can see it very nicely here, the ulcerating mass on the cinematic rendering. You can see it's very avid on the PET scan, large ulcerating mass, small bowel, no other areas of disease except for a few nodes. The diagnosis is small bowel lymphoma, an excellent example. Another case, back pain. There are multiple masses or nodes in the mesentery, and what's important, they're cystic. When you think about cystic nodes, you can think about lymphoma if it's been treated, but otherwise you think of things like Whipple's disease, which is really rare. You could think about TB. You could think about MAI is a good thought. This doesn't have the look of a mass like a carcinoid, which is vascular. It's not your typical adenopathy just from a routine tumor or lymphoma, as I mentioned. You can see it's stretching the vessels. There's no desmoplastic reaction. The vessels are not obstructed. And again, cystic nodes, you got to be thinking TB. You got to be thinking MAI. Clinical history is, of course, important. Again, trying to help you differentiate between inflammatory and neoplastic processes. And these were cystic necrotic nodes secondary to tuberculosis. Another case, mass sent for pancreatic cancer. You see cirrhosis, you see mass in the region of the head of the pancreas, but there's no common or intrahepatic duct dilatation or pancreatic duct dilatation. There are then nodes in the portal caval space, and if you look hard, there are nodules in the subcutaneous tissues. So this really isn't a primary pancreatic adenocarcinoma. Could it be lymphoma? I guess that's a thought. Soft tissue nodules, bulky adenopathy, large mass without duct dilatation. But now I'm also showing you that there are, in addition to the subcu nodules, there are lung metastases, multiple nodes in the axilla on the right, multiple subcutaneous nodules. So you can say, well, maybe I'm dealing with lymphoma. Lymphoma is a great mimicker. But when I say lymphoma, I've learned to say metastatic disease. And when I think about metastatic disease, I think about melanoma. That's probably the best bet. Here's the PET scan, multiple areas of increased avidity, multiple nodules in muscle, soft tissue, in the pancreatic region, in the nodal space. Okay, just really, really impressive. And that was metastatic melanoma to the pancreas and beyond. Back pain, large mass pushing on the stomach by the tail of pancreas. If it came from the stomach, I could think about a GIST tumor. If it's just retroperitoneum, I could think about a sarcoma. Doesn't look like a liposarcoma. Maybe a leiomyosarcoma is a possibility. Big tumor. It's not an abscess, I don't think. There's no air bubbles. And you can see on the image on your right, it looks like maybe it comes from the pancreas. So you can say, could this be a big cystic pancreatic tumor like an MCN with malignant transformation? You scan further down, there's no adenopathy. The small bowel looks good. You can see how large the mass is, intimate relationship to stomach, to the left kidney, but again to pancreas. And this was an unusual case. We think about Ewing sarcoma, typically bone, but 10 to 20% are extra-osseous. Well under 1% is extra-osseous arising from the pancreas. And this was an extra-osseous Ewing's arising from the pancreas. Okay, back pain, dilated pancreatic duct, abrupt cutoff. First thing you think about is adenocarcinoma. When you look hard or harder at that region, with multiple images, you can see there is a cutoff, but there is a nodule that's enhancing. Adenocarcinoma typically does not enhance. What does enhance? A neuroendocrine tumor. You can get small neuroendocrine tumors in the pancreas, which obstruct the pancreatic duct, and they have this serotonin excess, and that's what causes the duct obstruction. Satomi Kawamoto at Hopkins wrote the article many years ago. Beautiful example of dilated pancreatic duct with glandular atrophy. You know there has to be a tumor present. Could be an adenocarcinoma, could be a carcinoid. Obviously, when you look carefully at the images, the mass is vascular, and this is an excellent example of a neuroendocrine tumor in the body of the pancreas obstructing the pancreatic duct. Another case, back pain, tail of pancreas lesion, septations. Here it is nicely shown. Think about this looking a little bit like that extra-osseous Ewings, but I only have one of them. You could think about a serous adenoma, the septations. Age may help. They're usually 70-year-olds. Mucinous cystic neoplasm is usually 40 to 50-year-olds. They have septations. They can have calcifications. They're typically malignant or pre-malignant. You can see it very nicely here. So a cystic lesion, tail of pancreas. You can think about serous adenoma. You could think about an MCN. You could think about a lymphoepithelial cyst. But you really got to be thinking most about an MCN. Again, patient's age is helpful. And this was an MCN with low-grade dysplasia. If I show you this case, it kind of looks like the last case, but it only got about 5 times bigger. Complex cystic lesion, the septations are more impressive. The nodularity is more impressive. This is a much bigger lesion with bigger septations. Again, the same differential would apply. And when you go through this case, the more solid components really pushes you to moderate to high-grade dysplasia. And this was an MCN with high-grade dysplasia. So both cases looked a little bit similar, a lot different, but both with the same diagnosis. I think when we see nodularity, we can call high-grade dysplasia, but there's no way anyone's going to manage a patient based on your opinion, quite frankly. It's typically felt that all MCNs are pre-malignant at a minimum, and so they all are going to be resected. There's been some work now suggesting on small MCNs you might be able to follow them, but current work is take them out. Here's a great case, and oops, I told you the answer. But this was a patient with a renal cell. There are multiple vascular and hypovascular splenic lesions. I could think about metastasis to the spleen. I could think about an angiosarcoma. You could think about hamartomas, hemangiomas, but multiple masses that are solid. And then you look, the patient has had a right nephrectomy. That's metastatic renal cell carcinoma to the spleen. Clear cell renal cell carcinoma, whether it's to liver, to pancreas, to muscle, to bone, to kidneys, or spleen, will often be vascular. I've not seen many of these cases, but this surely is the best one I've seen. And here you can see the lesion washes out on delayed phase imaging and why the arterial phase is so important, though surely on the venous phase alone, you would have been able to see the metastatic disease present. Again, really nice example. Okay, chest pain. Large posterior mediastinal mass with bone destruction. Posterior mediastinal masses, you could think about lymphoma, you could think about sarcomas, but the bone destruction, you got to think about something in bone. You can see TB in bone, right? We see osteomyelitis, we see discitis. This mass extends downward, pushing the trachea and vascular structures forward. There it is in the sagittal view, centered at about T1, T2 with bony destruction, large soft tissue mass. So you can say primary bone tumor, lymphoma. What else? Not the best location, but chordoma involves the spine. Usually it's in the clivus or at the lower lumbar spine by the sacrum. But this is a large mass. It could be metastasis. It could be lymphoma. Those are all indeed possibilities. Bone destruction. You could think about infection like an osteomyelitis. This ended up being a chordoma. Just a really, really nice case of a chordoma. Chest pain. There's a lesion, 6th rib on the left. There's bone destruction and soft tissue mass, which you can see. If the patient had trauma, that could be an explanation. If the patient had infection, usually it's more pleural based. You can get things like actinomycosis, but it doesn't look like infection in the bone. It looks like something infiltration, but I couldn't rule out infection totally. When you get more images, you really appreciate the soft tissue mass that's present. You appreciate it especially on the coronal and 3D coronal images, very nicely shown. And this is the look. Here's the bone that one rib involved. This was a flat bone. We talk about osteosarcomas of ribs, they have matrix. We talk about Ewings, flat bone, smooth, destructive, without matrix. And this was a great case of a Ewing sarcoma. Chest pain, large mediastinal mass. It's located middle to posterior mediastinum. Yes, there are PEs everywhere, particularly the right main pulmonary artery, which is why the patient presented. You can look at this case, this calcification of the mass. You could say lymphoma, metastatic lung cancer, metastatic renal cell cancer. All of those tumors can go to the mediastinum, involve anterior, middle, or posterior mediastinum. Again, lung cancer, if you had a lung mass, would be a good thing to think about. This is mildly vascular. This ended up being biopsied. This was not lung cancer. It was not lymphoma. Here it is very, very hot on the PET scan in the mediastinum, right, in the heart, and was a paraganglioma. Paragangliomas occur in the mediastinum, usually toward AP window, but they can occur other places. The thing about paragangliomas, which are extra-adrenal theos, typically they're very vascular. This lesion has calcification, but it's not very vascular. So a very unusual case, something worth thinking about. Well, those are my 11 cases. That's all the time I have, and I hope you learn something from these cases. I hope you continue looking at CTisus. We have lots of great new stuff there, and we'll see you again next month. Have a great day, everybody.